Jillian has just started the recording.
Great, thanks, Peter. And we also have, I'm not going to have everyone introduce themselves because we want to get started, but we have Tom Leet, who is our policy manager for long-term services and supports. And we also have Heather Binglis, who works with Tom in the policy unit. And we may have other folks on from the department as well, but I can't see all the participants listed, so we'll leave it at that for right now. Julia, did you want me to jump right into our purpose?
Sure, go ahead and advance the slide, Jillian.
Great, thank you. So we at MaineCare have been working on this project for some time, and I really can't overstate my excitement at being able to kick off the stakeholder engagement this week. We have a rate setting system right now that is very complicated. It is often not consistent or easy to understand, not for us within MaineCare or the department sometimes. So from the provider perspective and then where there are member impacts as well, it can get sometimes even more confusing. And we all know that rates are really foundational to healthcare, and we need to make sure that rates are sufficient so that providers can do their jobs and deliver critical services to our members, and make sure that those members have access to care and that they are also receiving quality care. In addition to the importance of ensuring that we have adequate rates, as I may have insinuated, it's also important and good practice to have a consistent and streamlined and coherent system, both for administrative purposes on the state's end, but then also because the wheels just function a little bit more smoothly for everybody when we've got a machine that people understand. So making sure we have adequate rates, making sure we have a streamlined, rational, consistent system are really our overall goals, and doing this evaluation work is really the key first step to achieving those goals. This is our first round of stakeholder engagement today. We are going to have a second round. This round of stakeholder engagement is specifically focused on getting your input on the impact of reimbursement methodologies, how we pay you versus how much we pay you, and what impact that has on you as providers from an administrative standpoint, what impact it may have on how you deliver services or what services you deliver, and also whether or not those impacts trickle down to members as well. In our second round of stakeholder engagement, that is when we are going to focus on the adequacy of rates and potential impact on access to services. So one of our early deliverables from Myers and Stauffer in this process will be what we've been referring to as a benchmarking report. And that report across MaineCare services will look at rates for comparable services, both from comparable Medicaid states, from Medicare, and from the commercial side. And that will, it won't tell us the whole story, but it will be a useful tool to show us where it looks like we might have rates that are outliers, either on the high side or the low side in comparison to other payers. So we will also be doing that same kind of benchmarking, looking again at payment models, and so how we are paying for the care, to see whether there are obvious opportunities for where we should be taking advantage of alternate payment models, which I'll talk a little bit more about in a bit. So once we have that benchmarking report, that is when we are going to be reconvening stakeholders to talk about how much we pay and access to services. Also, this is really a listening session for Myers and Stauffer and for us, and so we won't be responding to questions during this meeting. It's really, I mean, a very basic question might be okay, but the point is for us to hear input from you. All right, so because some of the questions that we are going to be talking about in this meeting regard value-based purchasing, I wanted to provide a little bit of an overview of what we mean by that. And some of this could be old hat for some of you, but it may not be for all of you. And I really like to start out with defining what we mean by value, because I feel like it's a term that we throw around and don't necessarily really think about what it means all the time. So what I really like about the term value is that by definition, it's talking about the relationship between quality and cost. And obviously that relationship can get really complicated and has many facets, but to oversimplify it, if we want to improve value, there are two main things that we can do, right? If we are holding quality constant and we want to improve value, we can reduce the cost. If we want to hold hold cost constant in order to increase value, we need to improve the quality. So those are two simplistic examples of, generally speaking, how we improve value. And right now, under our fee-for-service system, we pay for volume. And so it's really not about value. We're going to pay you what we pay you for how many units of service you provide, regardless of how much that is going to cost and regardless of the quality associated with those services. And so when we talk about moving towards value-based purchasing, we want to have a way to tie that value in to the payments that we are making. Next slide, please. All right, let's see how much of this I've covered already. Another piece of this, as you probably gathered from the definition of value, is the idea of accountability for the care being delivered. And I will just say that whether we're talking about healthcare or government or the private sector, it's well recognized at this point that we all do better when we actually track our outcomes and have goals to work towards. So we can all agree that we don't want costs to be high and we want quality to be high, but to have metrics that we're tracking and working towards to get to that place can be a helpful tool. And obviously you can go too far if you've got too many metrics, and we agree and are aware of that as well. But it is important to try to define those quality outcomes and pay attention to them. And I'll say that within MaineCare right now, we do currently have a number of value-based purchasing initiatives, and we are actively working to expand the kinds of payment that we are tying to value. In fact, we have a specific goal. Right now, our estimate is that about 20% of MaineCare payments are tied to value-based purchasing, and by the end of 2022, our goal is to get to 40%. So really double those payments. And we will use the term alternative payment models, or APMs. That is a term that has been developed by an organization called the Healthcare Payment Learning and Action Network. HCP LAN has done some really fantastic work over the past few years to make sure that across the country we are using the same terms and the same definitions for how to categorize these different payments and how to move along the continuum to get to truly value-based care. And so they start over on the left of the screen with fee-for-service, which is what most of our healthcare system still is, as I said, where there's no link to quality or value. It's just we pay for units of service. All the way on the other end of the continuum is where you have population-based payment. And quality always has to be a component of all of these categories of APMs, including with population-based payment. But clearly, when you're also talking about payment models that intend to be more flexible and less administratively burdensome, so providers can have payment for all the important things that need to happen that aren't always face-to-face, population-based payments are very flexible, and they also put a lot of responsibility on the provider to be accountable for the cost as well as the quality. And so there are steps along the way, but this is the continuum that we're talking about. And I encourage folks to look up HCP land because they've got some great materials, and on an annual basis, they ask payers across the country to report on how much of the healthcare that those payers are paying for falls into these different categories. So MaineCare participated in that for the first time last year, and we will be participating again this year because it's nice to be able to benchmark our progress against other states and other payers as well. Okay, so again, I really thank folks for participating this morning. Your feedback is really critical, and we look forward to your participation in our next round of stakeholder engagement as well. I'm going to turn things back to Myers and Stoffer so they can talk about some of the rules of engagement for today, as well as the discussion topics that you all will be talking about. But thank you again for your time. Unfortunately, I'm not able to stick around for the session today, but I very much look forward to hearing all about it. Thank you.
Thank you, Michelle. So just to briefly go over, we have 5 discussion questions that we had posted ahead of time that we're asking all of the stakeholder groups. And we'll go through these one at a time. This is just an overview. Go ahead and advance to the next slide, Jillian. We just wanted to go over the meeting structure. I'll introduce the questions, and we are going to use the hand raising that's built into WebEx. It's not necessarily easy to spot, so it's right above your chat box. It's a little hand that barely looks like a hand, and right to the next of it is a megaphone. So if you can spot the megaphone, the hand is directly to the left of it. So we're going to ask you to raise your hand if you'd like to speak. Jillian will go through and unmute people. Once you have spoken, if you could unclick your raise hand so that we know that you're not asking to speak again, or you're not asking to speak on the next question. We move to the next question. I'll ask everyone again to raise your hand who wishes to speak. We have a limit on time that we have available today, so we're going to try to keep the questions to around 30 or so minutes each, depending on how many people have asked to speak. We may, if there's a bunch of people who want to speak, we may ask you to keep your comments to a few minutes. But if not, we're really just here to try to listen to gather information. We ask that you keep your comments pertinent to the topic under discussion. And yes, Jillian, also, that's a good point. If you are struggling to raise your hand, please use the chat box to chat at us, and Jillian will go through both the chat box and the raised hands to make sure that we have everyone able to speak who asks to. Please make sure when you're commenting that it's on the topic under discussion. We will be, as we've said before, but we want to remind, we will be recording and transcribing the meeting. The recordings will be up 24 hours, within 24 hours of the meeting, and will be accessible. Prior to commenting, please introduce yourself and the services you provide. This is just for our note taking to help us make sure that we're grouping comments associated to the right service. And if you're, rather than repeating a previous point, if someone has said something and you agree with that, please reference the comments you agree with to make it easy so that we can help us to gather those up. And then limit the comments to those related to the impact of payment methodology. Like we said, we're not talking necessarily about rates specifically in this engagement, in this stakeholder engagement today. If you want to go ahead, and thank you. Just a couple of reminders. Phase 2 will be an opportunity to comment on payment levels. We'll be releasing the schedule in early November. As well as the Phase 1 report that will benchmark payment rates to other states, commercial plans, and Medicare, and provide a catalog of the existing methodologies, as well as some recommended services that could be candidates for alternative payment models. And we always are happy to accept written comments. Rate setting eval at maine.gov will tell you this now at the beginning and then again at the end. If you would like to submit written comments rather than speak up, we're happy to accept those as well. Okay, so I'll start the discussion with question number 1. So what we're asking here is really how your current methodology is working for the services that you provide. So is it transparent, easily understandable? Does it create opportunities for you to be efficient? And one of the more important points is, does it reflect how you deliver services? So do you typically provide a bundle of services, but you bill for them separately? Does the methodology require you to bill in 15 minutes when really you provide services at a minimum of an hour or 2 hours or 3 hours? And so you have to bill that in an increment much smaller than you provide it. So that's kind of what we're trying to get with this question. If you could go ahead and start raising your hand if you would like to respond to this question, or use the chat box if you can't find a little hand.
I've got a first raised hand here, and that's Matthew Shank.
Hi, this is Matthew Shankwaler. I'm the owner of In-Home Care. We serve elder and disabled adults in northern Maine mostly. Thank you for taking my question. We often have situations in which our services are rendered, we get first on a 15-minute increment, but we often, using EVV, electronic visit verification, there's issues with clocking in and clocking out, and it's not exact. Those services don't exactly end on a 15-minute increment. And not only do our workers miss out on time that they've worked, but our agency misses out on time that we could bill for when that 15-minute increment is just short of what the full shift should have been, or just longer than the full shift should have been. So having a 15-minute increment in your methodology is, in my opinion, an issue, because it doesn't show the real time period served. Thank you.
Thank you. Okay, next up I've got Jillian.
Good morning, Jillian Jolliker, Chief Operations Officer from Assistance Plus, and I second the 15-minute methodology as not being an accurate depiction of the service we're delivering. No service that we deliver under home care is ever done in an increment of 15 minutes. PSS, and it is always delivered on the hour. And like you said, there are times that we don't get paid because we may go over the hour if there's an emergency. So PSS would be better delivered in an hourly service, or even like a bundled, block shifts, 2 hour, 4 hour. It's also not delivered, the methodology is also not delivered according to level of acuity. So we see a lot of patients that are low level, moderate level, and high. For example, if we were taking care of a morbidly obese patient, that could potentially require 2 staff opposed to 1, and there's no methodology that supports a higher acuity of care, or a patient that's come home from a nursing home and is total level of care. We get 1 flat incremental bill by the quarter unit, and it's not directly related to any sort of quality or patient level of care. The other concern on the nursing side is I've been advocating for years in the form of various bills that have been put forth in front of the legislature. One of those bills was passed. It was for Section 19. We did get a flat rate visit nursing bill approved, and I have been very diligent about following up on why that was never implemented for Section 96. And years ago, I was informed that it was just a publishing error, but I couldn't get it fixed. So the flat rate visit nursing, you should not pay a nurse based by the 15 minutes they spend face-to-face with their patient. That methodology doesn't work, because I think we all know that behind the scenes, especially during COVID, that nurses are doing a higher level of care that's away from the patient, whether it be making sure medical supplies, or making sure that they're safe, or in the beginning that they were accessing food. So I would recommend that nursing, the intermittent nursing, not the pediatric nursing, the house-to-house well checks and reports to the physician be reimbursed on a it could be both models, an hourly model, or that it be reimbursed on a flat fee model. So, you know, there aren't concerns that, well, your nurse wasn't in front of the patient or your nurse was in the parking lot during COVID. That's come up a lot, that, you know, there needs to be a different methodology of payment for the intermittent nursing, the specific to 2-hour visits where you might see 25 patients a week. And I think nursing would appropriately fit, and this might be a later conversation I remember from yesterday, it could be a good value-based purchasing model. There could be some really good quality care delivered for nursing. I'm not sure how you would deliver that care with PSS because I've never seen that. Perhaps other states have that, but I would say flat rate visit for nursing as an option for people that don't want to FaceTime their member. And also nurses not get paid for any indirect time spent with a patient, and that's really a concern. And there is a critical shortage, so it's, you know, different payment methodologies are really warranted in nursing for sure. But also just that acuity of care, I was on the long-term care workforce and we did a lot of work behind the scenes on this. There's no methodology that supports us paying employees that have 20 years of experience or employees that can deliver higher acuity of care or just different care patients. There really should be different tiers of payments, like 3 different levels of patients. And this current model does not support that.
Okay, thank you, Jillian. Next up, I've got Betsy.
Yes, this is Betsy Sawyer-Manter. I'm the CEO at Seniors Plus. We are a service coordination agency who does work statewide. We are the largest care coordination agency in the state, and we are also billing in 15-minute increments. It doesn't work for us. We're not a 50-minute hour kind of situation. Most of our stuff is done telephonically. We have a lot of paperwork shuffling that has to happen around care coordination. Those are not billable activities. And so we have a lot of work that we do that we are not reimbursed for. And it simply would make much more sense for care coordination to be a PM reimbursement methodology. The 15-minute just has always seemed really inappropriate for the type of work that we do. We lose in efficiency. For example, if we have 5 clients who need staffing and we're talking with one agency, and we can talk about with that agency the need for those 5 clients to have staffing, which client do you bill for? It doesn't make sense. It forces us to be less efficient than we can be. We have very high caseloads of around 100 clients per case manager, and to be doing the same work over and over is a really, really inefficient way of managing our work. So I would say, no, the methodology we're using is not working for us, hasn't worked for us for a long time, and it doesn't pay for the service. Thank you.
Good. Thank you for your comment, Betsy. Next from the chat, I've got Nathan Miller. Sorry, one second. Let me find. You should be unmuted now.
Hi, can you hear me?
Yes.
Great. My name is Nate Miller, and I am Senior Program Director at Spectrum Generations Bridges Home Services. I agree with everything that everybody has said so far. I'd also just like to say, though, that one of the biggest fears is that this methodology is creating underserved populations. So Jillian was talking about consumers that have needs for higher technical assistance. If it costs more to provide services to those consumers, they may end up not being served because of that. And then there's also consumers in rural areas where the cost of providing services is considerably more just because you need to get to them. So I'm worried about those underserved populations that need higher technical assistance and live in rural areas under this methodology.
Okay, thank you, Nathan. Next up, I've got Matthew Shankwaler.
Hi, I'm going to piggyback on what was just said about the rural areas. Because we serve mostly northern Maine, there are a list of clients that are not currently being served in the Fort Kent area, Presque Isle, all those areas up there. And the issue of finding staff is twofold. Can we pay them enough, and can we even find them? I have been successful at finding staff in areas that have a decent population. Medway, Millinocket, Lincoln, Milo, Dover, those areas we can find staff at, and we can hire them and we can employ them. But areas further north, it has been extremely difficult for us to even find someone to work. So if we were able to be compensated to have our staff travel that far to provide those services to those individuals up there that aren't getting services now, that would be very helpful for not only the client, but for us to be able to do that work. Thank you.
Okay, Matthew. Next up.
I didn't hear a name.
Sorry, Jillian, that's you.
Oh, sorry, you cut out there. One thing I thought about, this methodology does not work for care of the sick patient. So for example, in nursing, right? So we note that this member has a weekly nursing visit, and we've done the nursing visit, and we reach out to EIM and they decline the PRN because there isn't one. This sort of methodology doesn't work to keep patients at home, because this week, the example that we had was a client's catheter fell out. We have no way to get the catheter back in because the patient is at their cap of their program. So the catheter had to stay out, but instead of staying out, we had to send the member to the emergency room during a COVID outbreak for a potential $1,000 or $2,000 Foley catheter reinsertion, when we could have just approved a $55 nursing visit to put that Foley catheter back in. So if this were more of a value-based purchasing method, I could have done that visit, but it's really tough because sometimes we have the ethical dilemma of delivering free care to meet the need of the patient, but we do that so much, it's not a cost-effective measure to delivering the service. So if this were value-based purchasing, or like the per member per month payment, like Betsy mentioned, it would be much more effective and quality driven, and it would keep patients out of the hospital. And I've been saying this for more than 10 years, that this service doesn't focus as much on primary interventions as it does tertiary, or once you have the problem, we focus on the problem, but we really should be proactive on preventing. And unfortunately, this methodology does not support that model.
Thank you. Thank you for your comment, Jillian. Next up, I've got.
Hi. Hi, I was just muted and unmuted. Can you hear me?
Yes, we can.
Great, thank you. This is Nate again. One more thing I wanted to mention too was that there's really a safety issue. I have concerns about injuries for staff when they're assisting clients with lifts and transfers. And then also the 15-minute increment isn't exactly conducive to EVV payroll, as there's a 7-minute rounding for payroll. So we end up getting we end up providing a lot of services that we can't be reimbursed for. I think that's it. Thank you.
Thank you, Nathan.
Okay, great. So I don't think we're seeing any other hands, and no one else in the chat box. Is that correct, Jillian?
That's correct.
Okay, great. So thank you so much for your comments. We're going to go ahead and move to the second question. So this is really talking about whether or not the payment methodology creates incentives. And you guys have touched on this a little bit already, but is it creating the right incentives for quality of care, access, providing primary and preventative care, integration, care coordination, how members use services? Is it structured in a way that avoids abuse or fraud? We've had questions about the last piece, and so one example that we were given in a prior meeting was that the way it was billed, for example, for dentists, was that they have to sort of bundle their services themselves, and it doesn't necessarily reflect what was done exactly in the medical record, even if it was bundled correctly. So there, is it structured in a way that is not reflective of how you're providing the service, and could lead to payment error as a result, is really what that bullet point is about. So we'll go ahead and again, raise your hand or chat in the chat box if you can't find the hand raising, and we will unmute and accept comments again on this section.
Sorry. PowerPoint decided to go through. So first up, I have Nathan Miller.
Hi, thank you. So I'm currently in a leadership position where I hold people accountable for billable units, but I've also had the experience of providing direct services within this methodology. And being in that position, you start the day off strategizing how to get billable units when really you should be focusing on quality of care and the person's care plan. So no, I would say that this payment methodology doesn't create the right incentive for quality of care. Thank you.
Okay, thank you. Thank you, Nathan. Next up, I've got Jess sorry if I pronounced that wrong.
Sorry, I was just I was typing in my comments. So I was suggesting that in terms of quality of care, in particular, payment for PSS services in home care provides no way for that worker to have a preceptor. And that is one of the ways that we've identified as an opportunity for people to earn while they learn. And so definitely would like to consider having some sort of payment for supervisors or people who have been in the business for a long period of time to be preceptors, to be able to mentor new PSSs as they're entering the field.
Great, thank you, Jess. Next up, I've got Jillian.
Good morning. Jillian Jolliker again from Assistance Plus, and I'll speak to some of the topics really from our Workforce Commission. So there's no incentives here for the delivery of quality care. There's no benchmarking. There's no measurement of this quality delivered within this service. So that's concerning. And then this is a very task-driven service, and I'd like to see somehow that methodology change and really focus on a whole person approach rather than, okay, so you have 10 minutes today for bathing, you have 15 minutes for transferring, you have 10 minutes for toileting, And if you don't do that, you should reduce the care plan by an additional 10 minutes. It's very tedious and administrative burdensome to deliver care in a task-based world. I think it really needs to be approach of whole person care and a different methodology for taking care of people as a person rather than a task. This is a program that has long wait list. Patients have poor access to this care because of that wait list. There's also lots of care coordination that happens that's placed on the supervisors. I mean, you do have EIM involved, but so much care coordination happens at the agency level, whether or not we need to make referrals or contact physicians or notify family members or provide more supervisory assistance to a new employee or to an employee that's been there longer with a more complex client. There is no reimbursement for any of that indirect time, and there is no reimbursement at all for a supervisor in this model. And like Jess already said, there's no mentoring reimbursement. Part of the Workforce Commission's work is we're really focused on making sure that people have mentors throughout their employment, somebody that they connect to that does the same type of work they do and that can relate, not a supervisor, but somebody just like them. This model also does not support tiered employment. So if you have an employee that's 25 years, and I do, or if you have an employee that's been with you 1 year, they are making the same pay because the reimbursement and the methodology has not supported them to get any additional, experience pay. And it's created a wage compression issue. There is also no advancement in this model. Again, if you went back to we have a level 1, level 2, level 3 client, I'd like to see some sort of tiered reimbursement, higher reimbursement for employees that have higher skill sets, whether or not they're trained in dementia care, or they're trained in diabetic care, or they're trained, to work with patients of different diagnoses should have different types of reimbursement models so they get more experienced caregivers. I can't really speak to avoidance of abuse and fraud. I mean, it's pretty rare that those types of things happen, especially now, that we're all starting the process of EVV. But there is a significant amount of unfunded care that goes on in this model. None of the high level administrative burden you have within your office is reimbursed, and the methodology does not support this delivery of care. It also does not support primary and preventative care. There's no collaboration that we can do with anyone that's paid for. Even if it's required by licensing or MaineCare policy, there's nothing outside of that face-to-face time with that 15-minute billing. There is nothing that's reimbursed. That's all I have for now.
Okay, thank you, Jillian. Next up, I've got Betsy.
Yes, again, Betsy Sawyer Manter from Seniors Plus. And I just would like to say, when Jillian says EIM, that's a program of Seniors Plus, just so you know, just because I know it's confusing. People say EIM when they really mean Seniors Plus. So I agree with Nate and Jillian and everyone who's spoken before me. I think that the payment methodology does not create the right incentives for quality of care, because it is about checking boxes right now, because that's what you get paid for. You get paid to do certain activities, and it's very task unit and it's very unit driven. You've got to get the units in order to make the money, in order to pay the staff, and it still doesn't break even. But I also think that if we went to a different methodology, like a per member per month, people could really focusing on the folks who have the greatest need. We have people who are very stable on our caseloads, and then we have people that have very high acuity. And there's no differentiation between those with high acuity and those with low acuity in terms of the number of units of service that we can deliver to them in any given period of time. And so what ends up happening is we have people who don't have any units, and we can't get reimbursed for them. And we are told, keep working with them, but we don't have any way to get paid to work with them. And it shouldn't be about payment. It's always about payment and not about the right stuff, which is about the client and the work that we're doing with the client and the quality and the care that we're giving that client. So again, I think the incentives we have right now are the wrong incentives. Thank you.
Okay, thank you, Becky. Next up, Nathan, did you have another comment?
Yeah, thank you. So I did raise my hand a while ago, and everything that Jillian and Betsy have said is 100% correct. I think when Jillian was talking about supervision, really what she's talking about is oversight, and I think that directly relates to quality of care. She also talked about paying staff, differently based on their skills. And that goes to a point I wanted to make on training. There's no reimbursement for training. There's no reimbursement for benefits. So often those things are cut when payment isn't sufficient. It also creates more work for us because we end up spending a considerable amount of time tracking authorizations, and that becomes a burden when we could be doing other activities that increase the quality of care. And then when Jillian mentioned that the pay is the same regardless of how long the staff has been there, it's also the same regardless of the acuity of the client. So some PSS don't want to take on those more technical clients because they're going to get paid the same regardless of the task that they're performing. Thank you.
Okay, thank you. I think, Jillian, you had another comment about auth.
Yeah, there's this new phenomenon that's existed in the last few years, and I think Betsy can speak to this better than me, but when Nate mentioned the authorization burden, it is real. We spend every day monitoring authorizations, making sure we have them, making sure we're staying within them. And it isn't quality based to do that. So, and then what's happening now is we used to get authorizations that said, this is the service you're delivering, this is for how long it's good for, and this is how many hours. But now we get the service authorization is extended, and there's a lot of tracking in a new way because now we have to extend it on our own end without the actual authorization being extended for us to see. So then we have to track that, and then we'll get another email. This authorization is re-extended, and it's creating an additional financial burden on the organization that wasn't part of the original methodology that was assessed by the Burns rate study. This new phenomenon didn't exist then, so we're constantly re-extending OSS, and that comes at a significant administrative and financial department expense. And this is something that we've seen historically over the multiple changes of assessment agencies that have occurred when it goes out for bid. So it's something I've only noticed in the last, Betsy could speak to this, I would say 3-4 years. And in this year during COVID, it's much more extensive, and it's very burdensome for organizations to have to track hundreds of thousands of members' authorizations, extensions, re-extensions, and to have a good method in place for that when we're critically short-staffed already. So thanks for bringing that up, Nate. That's a very good point.
Okay, thank you, Jillian. I'm going to send it over to Betsy now.
Yeah, this isn't really about payment so much, but what Jillian was speaking about, this is really a result of, and we're in the same boat. We all have had to do the same work over and over and over and over because of re-extensions. And a lot of that had to do with the changing of the ASA, and that happened twice within a 12-month period, 3 different ASAs. And so the amount of backlog there was the system just got really bogged down, and it has created an incredible amount of extra work that is not reimbursable. It's all behind the scenes work that's not reimbursable because it's not direct care and it isn't factored into the rate. So that's, I guess, how it ties to the rate. I hope it's an anomaly. I hope it's something that doesn't continue. It has continued during COVID. I'm getting a lot of complaints from my staff. I'm having to hire more people because we can't keep up with all the over and over and over paperwork we have to keep doing. So thank you.
Okay, thank you, Betsy. Jillian, did you have a comment?
I do. So Betsy just brought up a good discussion, and I don't know how that exists, but in my 25 years at Assistance Plus, I mean, historically, we had one ASA organization that I can remember that existed for the full first, and Betsy can tell you better than me, maybe 20 years. And then, like she said, over the last couple of years, where there's one, another, and I don't know if through this methodology that can be looked at, because that has a very significant impact on our ability to deliver a quality level service. When first year we're dealing with MDON, then we're dealing with Gould, and then we're dealing with Kipro, and then we're dealing, you know, most systems remain stable with one assessor agency that's doing a good job. I'm not quite sure why that changes, or if you have to make a change if it's working. But I think that the methodology of how you determine who our ASA it needs to be looked at, because if it's not a well-functioning, well-oiled machine, it impacts the delivery of our service, and it also subsequently lowers the quality of what we can do when we're re-extending authorizations for members that have maybe not even been looked at for a year or 2 or 3 years. So they just keep extending it. Well, that member may have higher level needs than was known 3 years ago, and we just keep extending it. And the flip side of that, what I've also seen, which may have led to change of ASAs, is some not very well put together assessments. So we get the referral from I'll say Senior Spectrum, which is EIM, we get it from. And then we may have to form a rebuttal and say, whoa, you know, this assessment was all spent 3 hours in patient, and their needs are way higher than what this assessment lists. So sometimes the assessments aren't spot on either. And this is our patient, and we know them pretty well. And there's a really difficult process of getting those authorizations fixed. And I don't even know that they can be fixed anymore under this new ASA. But what I see now is we say toileting, we're not doing toileting, or add these 3 things and we can't add them or we can't take them off, but we have to make a side note. And again, another tracking methodology, we behind the scenes have to say we're doing these 5 things that can't be removed from the auth, and we have to make mental notes that we couldn't get these tasks removed. So I don't know if during this process you can look at the ASA, because that's definitely been a concern with the frequent changes year to year. It's impacted our business significantly. I don't know if others on this call have that same experience, but the assessor changes have been pretty brutal on us.
Okay, thank you for commenting, Jillian. Next, I have Nathan.
Hi, so I think Jillian's right, but broader than just ASA changes, there's changes to everything. And so this current methodology was a picture of a specific time and place, and there wasn't anything built in to address regulatory changes, changes in the environment in general, and cost of living increases. So I'd hope that a future methodology would acknowledge that there are going to be changes in the future and accommodate those. Thank you.
Thank you, Nathan. Thank you, Nathan. Let's see. I'm not seeing any other raised hands. Betsy, did you want to make another comment, or?
Oh. Nope.
No, okay. No worries. Nathan, I might have cut you off too early.
Yeah, so one more thing I just wanted to mention, that if authorizations could be broader, I mean, I think that would help. Some authorizations are weekly, and going back to the burden of tracking authorizations, it creates just a lot more difficulty in managing and tracking authorizations. Thank you.
Okay, thank you, Nathan. Jillian, I think you had a comment on nursing.
I do. So the other thing I thought of over my many years, and I sound like I'm really old, but I'm not. But the way the nursing authorizations are given to us, I think there could be a better method. Again, this is a very task-based service, so I'll get pulmonary, genital, you know, and all these individual tasks. But I have to tell you, the nursing board requires we assess all of them. So I'm not quite sure why we have to say assess GI, assess emotional, social, assess pain. We as nurses do assess all those things. So back in the day, many years ago, we would just get an authorization that would just say general health assessment, because that's what we're going to do every time. Like if you want to also add med prep or venipuncture, that's an additional unfunded service there. But I think it would be, it's so administratively burdensome to say all of those individual things when you could just say general health assessment, and that could be defined as these 25 things you're going to do each visit. It makes less on doctor order tracking. It makes less risk for missed genital urinary on it, you know, because we're going to assess everything every time. So again, if we moved away from that task-based mentality and moved more into quality, we could spend less time on the paperwork and more time focusing on the patient. And that has been something I've hollowed out from every rooftop for the last 20 years. So if we could look at that, more of just a standard, you know, health assessment, and then the add-ons of whether that be venipuncture, med prep, Foley catheter, those types of things above and beyond just a standard nursing visit. And of course, those above and beyonds need to be compensated because currently none of them are.
Thank you, Jillian. I'm going to unmute the call-in user to hopefully see if they want to comment. Kristen, is that you?
Yes, it is. Thank you very much. I wanted to add about potentially some solutions, and I completely support that Seniors Plus, Elder Independence of Maine have a per member per month model. I think that makes perfect sense. When it comes to home care services, our authorizations, the way that we actually have to bill them, are on a weekly basis right now, which means that on a Friday afternoon, if as someone's about to end their last minute of service, the consumer asks them to make them a sandwich so they can eat it on the following day. The PSS does that. Now they're over by maybe 7 or 8 minutes. However, that means that payroll-wise, we pay them for 15 minutes of that time. We can't bill for any of that time, and we can't take it away from the following week. The same thing is that if someone goes over on a Wednesday, then that means that we're taking it away from that Friday visit. There is already precedent to have an annual service authorization number of hours in both respite hours and in the adult daytime world. And I think that if there was an opportunity to have an annual set of hours for PSS, that, for example, if someone goes into the hospital, those hours just are lost. Additionally, when they come home from the hospital, they may need higher care for just a week or so. We're not going to get the assessing agency in to be able to authorize 1 week's worth of extra care. However, if it was an annual basis that the agencies are coordinating, the agency would be able to potentially schedule a PSS for extra hours during that first week home, which could potentially avoid a rehospitalization as well. So I do think that there is potential here where if either per member per month or just changing the way that the authorizations are tracked. So those are the types of administrative burdens that I think sometimes with authorization tracking, besides just which authorization is up to date because of a delay of being reassessed. I think that there are times where we're saying, oh, we had to change this authorization from a Tuesday to a Wednesday, or we have to change, can we change hours from here to there and having to get special circumstances, even because of special circumstances, and it takes a lot of additional time for both the agency and Seniors Plus when we're coordinating for that extra week to the hospital. So, thank you.
Okay, thank you, Kristen. I think we got your comment, but I did want to note that you were cutting in a little bit in and out. Just as a note, I don't know if anyone else was hearing that, but I think I was able to piece together your comment.
I could submit it in writing as well.
That would be great. Yeah, you could type it in the chat or anything like that. That would be perfect. Just to make sure we recorded you correctly. Thank you. Let's see. I'm not seeing any more hands or anything in the chat box. Julia?
Okay, great. So thank you so much for all of your comments. We'll move to the next question, question 3. So this is really looking at whether your payment methodology is equitable for the services you provide compared to other types of provider groups. And I know this one's a little bit challenging to answer, especially if you aren't aware of how other provider groups within your service area are reimbursed. But if you do have some concerns about whether they're updated, determined and updated at the same frequency, if there's a similar amount of administrative burden, and if one service area maybe is getting incentives for quality and access and one other service area isn't. So any information you have about how you feel, if there's equity in the methodologies across your service area. And we'll go ahead and ask everyone to, again, raise your hand or chat at us in the chat box so we can unmute you.
Okay, thank you, Julia. The first person I have is Nathan.
Thank you. One thing I'd say is that there isn't equity. You've got a lot of different services and a lot of different providers that are all trying to get rate increases, and they all have access to different resources. So really, I mean, should we be determining payment based on who has the best lobbyist? It just seems like a really bad way to go about this. Thank you.
Thank you, Nathan. Let's see. I am not seeing any other hands or comments on this question. Oh, just got one. Jillian?
So in this realm, we deliver per member per month value-based purchasing services within our agency and our mental health department. And I do not think the delivery of nursing is equitable and based on quality. I think there could be room to develop that with PSS, and I'm not sure what that would look like. These services that we provide have a very high level of administrative burden, whether it be high level auditing to comply with MaineCare rules or the tracking like we talked about of the OS. You require a lot of internal staff to do all those things. And what I've noticed is a flat rate could address that problem for nursing, but we haven't been able to fix the issue with it only being applied to Section 19 and not applied to Section 96. Again, that spending 15 minutes face-to-face for an hour with your patients inside of their house doesn't work. There aren't really any incentives for quality. There isn't any sort of reimbursement for anything that you do outside of that patient's home when you're a nurse. And I'm looking at my notes here. I just strongly feel that this nursing specifically would fit in a value-based purchasing model. And I think somehow we could build PSS, just like Kristen was talking about the OS, currently the way that's structured is you can only like bill by the day. So it's broken up. You have 7 hours this day, 7 hours tomorrow. And we can't transfer any of those hours to another day, even if the patient came home from the hospital and had higher level needs. But at other organizations, whether they're billing privately or Medicare, they have more of that fluctuation. We also run into a lot of problems with our nursing department when other organizations we find are in the home and we've done 2 or 3 visits, and then there might be this concern that we can't even get paid because we weren't notified that they had an acute skilled agency in there. And it's my understanding that some of those services bill capitated flat rate per member type service delivery, and that's not something that we've ever had access to in this type of a service. And I think all of us know that currently the rate that we have is still not enough for the service we're delivering. I'm trying to remember what the next question is, but we don't get for any collaboration, no team meetings. We don't get paid if a patient cancels. We don't get reimbursed for using Health InfoNet or for accessing our patients when they're in the ER and connecting with them to make sure that they come home and stay home and that we meet their needs when they get home. There's no reimbursement for appointment follow-ups. There's no reimbursement for physician's orders or for the delivery of treatment planning. Their emergencies aren't reimbursed. I've been at a client's house when I had to stay a couple hours over because they had an emergency where they came home from a nursing home and insulin to be found with an insulin dependent diabetic. And none of that is compensated because it goes above and beyond those 4 15 minutes we're allowed. We get no reimbursement for mandated reporting that we have to make at least, we see probably 75 of those a year at our organization just for home care. There's no reimbursement for mileage or travel, and we don't get paid again for any of that face time. And the other thing that we're running into is we're losing our nurses at a quicker rate because they're of the independent rate that's offered through MaineCare. That's only $10 less than what we're getting as an organization. So we've lost like 2 or 3 nurses in the last couple months to discovering that they can get like $44 an hour to take their nursing clients with them, essentially. Leveling that out, or nursing won't really be around much longer. The intermittent nursing.
Okay. Thank you, Jillian, for your comments. Julia, did you want to make a comment?
So we did get a chat question about the challenge of answering this question if you don't know how other services are reimbursed compared to what you do, and I get that. And normally in other services we would say, are you paid differently from other payers? And that doesn't always apply to the services offered under here who may only be funded under Medicaid and limited funding from other payers. So I think just maybe if you had ideas of how the methodology maybe works in other systems or other states, or something that is an idea of what you think might work better here that you're not seeing, might be a way to think about how you could answer this question, if that's helpful.
Julia, next I have Matthew. I think he's the one that gave us a comment there.
Hi, this is Matthew again with In-Home Care. I thank you for addressing that chat question, but this is to piggyback on the last person who was speaking when she was referencing self-directed care or independent providers versus company providers like I am. Since I purchased this company about 19 months ago, and we're doing very well. I'm very happy that I'm in this space, and it's really nice to see what we do for our clients every single day. It's one of the reasons why I got out of real estate. But the self-directed portion of PSS work, and I guess they have that choice for nursing work as well, is a distraction to our ability to execute on that client's behalf. And we have one client, for example, she has 3 self-directed workers, and we plug the hole where their self-directed workers have chosen not to work. We plug that hole on weekends and evenings because those self-directed workers are getting paid $17, $18, $19 an hour. And then we get reimbursed what we get reimbursed for to put someone in those more difficult times. And our worker says that when they go in, they have to pick up the slack for the self-directed workers because the client is not reporting the real work being done by the self-directed individuals, therefore putting more of a burden on our staff to do things like cleaning and cooking and shopping and whatnot. And that is, and I believe the reason why that is because the client, let me back up for a second. With our EVV system, we can see what's being done in real time. We can see what our worker checked off on doing, what they didn't do during that shift. With self-directed individuals, that burden falls on the care coordinator, I believe, or the agency, the like EIM, to monitor or I forget the name of the other agents, the other coordination company that does mostly self-directed staff. But that burden falls on that agency to figure out what that self-directed worker is doing. And I see a conflict between self-directed and company managed. There's definitely a conflict of interest, and while I respect the clients, I respect the idea that giving the client the ability to direct their own care is a good thing overall. The methodology and the management of it is causing agencies like mine difficulty when there is a self-directed worker in that plan of care as well as one of our staff members. Thank you.
Okay. I'm not seeing any more hands or anything in the chat box.
Okay, great. So we can move on to our next 2 questions, which are really about value-based purchasing and administrative requirements. So you guys have talked a little bit about so far where you feel like value-based purchasing may fit in, and really just kind of asking again, recognizing that the methodology doesn't seem to be consistent with value-based purchasing based on your comments already. Is it consistent though with any other value-based purchasing approaches that you have in place through other payers, possibly for other services? And then also, are there administrative requirements related to your methodology that are specific to MaineCare that places on you that are burdensome? And I know you guys have commented on some of this already, but this is kind of like wrapping up. Are there any other additional ones in particular that you haven't already mentioned that you'd like to talk to us about?
Okay, Matthew, is your hand up for this one, or is it still up?
No, it's not. But what it would be nice to have is for someone to educate us a bit on what a value-based purchasing model looks like in our theater versus asking us what we think about it. I have no idea what to think about it unless someone gives us an example of what we're supposed to be considering.
So to provide more context around, the value-based purchasing, are there any value-based purchasing models that you have heard of or that you've seen in place for other types of services that you feel might be helpful for the services that you provide, whether that some examples might be, you've talked a little bit about, the flat per member per month, or which is an alternative payment model, also looking at ones where you get quality payments based on achieving certain outcomes and what those outcomes might look like, or that you look at different types of ways to structure payment that direct the focus away from the incremental task-based service ops into something that's more comprehensive, that, at the far end of value-based purchasing, there's the assignment of risk. So you're going to take on the full care or the full care within your spectrum, helping this person to achieve health outcomes. And there is a bonus payment for when you achieve it. And then there is a holdback for when you don't achieve it. That's like the far end of risk-based APMs. And then somewhere in the middle where you're working towards, you get a structure of payment that allows you to work towards a focus on quality and value of care in an efficient way, as opposed to all the incremental, do this for 15 minutes, get paid for 15 minutes system.
Okay, thank you, Julia. First up, I've got Jillian.
So I think we've identified consistently throughout this call that the current delivery of Section 19 and 96 does not exist within any sort of value-driven model. And again, I go back to, we have a behavioral health home, and there are several components of that behavioral health home. You can have your case manager, you can have a peer support specialist, you have a registered nurse, you have a psychiatrist, you have a medical doctor or a nurse practitioner. And it's a model of care that's delivered through a whole person approach, and it partners behavioral with a medical model. And I think I'm a big pusher and advocate for this type of service. We've been doing it for 5 or 6 years, and I've talked to MaineCare on many different levels, many different conversations about my belief that many of the services that we're delivering could be done on a value-based model. I'm not aware of any home care model in Maine or any state close by that has any model close to this. I'm aware of some models in other states that I don't really support, but I think you could extract some of that and have a delivery model with personal care and nursing, and potentially, I don't know how you would bundle the payments, or if you separate them, or you have to do pass-through payments, but I agree that Seniors Plus definitely should be paid on a per member per month. I mean, we shouldn't be, a lot of times us as an organization too, we're looking at, we have to stop care at a certain point. And if we had that flexibility of value-based purchasing, it would be more outcome driven and less time task oriented. Well, we only have 15 minutes of this time, or, oh, we didn't do locomotion, toileting, and bathing today. Let's reduce because that went on for 3 weeks. It's too tedious and not focused on quality. But I do think, as compared to the behavioral health home model, that we could mimic something very, very close to that for home care, and have an effective payment method that would work for organizations. But no, currently there is nothing like that here in Maine that I'm aware of. It may exist in the Medicare world, but I'm not in that anymore. But I think it should be value driven, and it should be incentivized when you're doing a good job or you're meeting. I think it's very important, if we move towards a model, that you get stakeholder input on what the goals are, or what we're measuring, because sometimes I see in value-based purchasing models that if you're measuring, for example, A1Cs, that might not be value-based driven for everyone. It would have to be, we would have to collaborate more on what those goals are for, to not penalize a provider for not meeting it if it's out of there. A lot of times I see that the goals that are set are ones that providers can't attain because it's out of their ability. Like, you can't necessarily influence a patient to lower their A1C. So it would have to be something that we agreed on was our responsibility and not patient driven. Do you know what I mean? sometimes those goals are very skewed and not don't really line up.
Thank you, Jillian. The next person I have is Nathan Miller from Chet.
Thank you. So one thing Jillian talked about earlier in this conversation was different levels of acuity. I think that models that take that into account are better. I think, also Kristen mentioned adult day programming earlier. Because of the payment methodology, there's regions of the state where the service just doesn't exist to people. So a methodology that might actually like support that service and make it accessible to people might be like an annual authorization. So if this person wants to use Daybreak, like they don't get like a set amount of hours each week, they get an annual authorization. The Daybreak program gets that financial support, and then that service is available to that consumer whenever they need it. There are methodologies that are more person-centered, and I think we're going to have to look more at that as demand for services increases and we're unable to provide all the services that are authorized. So some people are authorized for a service and they're just not going to get it because there's not enough staff or because they're in a rural area. But then maybe those resources could help them in other ways that they could determine. So they could say, this is what I need to be able to remain at home and live independently in the community. And then they can spend those resources on that service. I think an example of that is snow removal. Snow removal is the biggest source of staff injury for home care workers at Bridges Home Services, but it's not a service that is reimbursable. So it's a service that we end up providing because the consumer needs it. If we're going there to provide home care services, then they're obviously going to have difficulty with this task, and it's going to prevent them from receiving other services. There's a lot of oil companies that won't deliver if a path isn't shoveled. So there's a lot of individuals out there, and the needs for individuals vary. But this methodology doesn't take that into account. Thank you.
Thank you. Next up, I've got Matthew.
Hi. So in answering the question, I think Jillian and the other gentleman that just spoke definitely answered the question, is that our current methodology, there's no value-based measurements whatsoever. My mother ran a DSP type agency in Florida for several years, and when it wasn't a huge company, she was the only employee, and I could see how the services that she rendered to those individuals with intellectual disabilities, they could be measurable. To give you an example, finding someone a job or helping them move into an independent apartment for a certain period of time. Helping them achieve certain independence goals like using public transportation or, again, goals that are measurable. And in looking at our clients, the clients that our company has, for the majority of them are on a path that is not, it is not something that we could likely expect the individual to overcome that disability, or age isn't overcome. You can't overcome age. I guess you can with physical fitness and with a good workout routine, but those are consumer directed activities. We can only recommend and suggest so much. And so when we come to this point of determining how our goals are going to be measured, it was mentioned they have to be agreeable to the consumer as well as to the agency that's providing the services. They also have to be achievable and measurable and relevant to the consumer. And if you look at the needs of each individual consumer and the ability of each individual agency, I'm seeing a beehive in front of me in terms of what we can actually wish to measure in terms of value-based activities in this elder care, permanently disabled adult services 19, 16, and 63. If anybody has any opinions about that, I would love to hear it, either offline or here. Thank you.
Thank you, Matthew. Next up, I've got Dale.
Hi, thank you. I'm with Community Health and Counseling Services. So I just, the comments are related to value-based purchasing. I think it's really important to understand the nature of the services, how it's delivered, particularly in our rural areas, because there are a couple of things that really factor into getting it right if that's the approach to take. What I mean by that is that in order to really establish a reimbursement that will allow for this type of an approach, there does have to be recognition in terms of establishing reimbursement that addresses and identifies complexity of care, because the complexity of care also relates to the intensity of services, which is related to the outcomes. And if the reimbursement is not set up in a way that recognizes the ability for organizations to provide whatever is needed to get to those outcomes, which relates directly to the complexity of that care need, then all we're doing is setting up a system where we say we have value-based purchasing, we set outcomes, but we disconnect that from what's required and what's needed. And another really important consideration is that sometimes value-based purchasing is set up with a population size, an expectation that if you have a large enough population, the reimbursement methodology works to support that value-based approach. But we have to recognize that with the services we're talking about, that population size may not be sufficient to really support that. So it's a really, I think, an important part of this as this is being considered, to keep in mind those elements in order to establish a methodology that really does support from start to finish a value-based approach.
Thank you, Dale. Next up, I've got Betsy.
Hello again. As I think about value-based purchasing, I think I have to go back to what is the intent of these programs. And I think that's sort of a starting point, because we're not going to have value based on every individual client care plan. It should be universality. What is the intent of the program, and what is the value we want to get out of delivering these services to people who are qualified for these programs? And so I don't think that the methodology we have right now is consistent at all with value-based purchasing, from all the reasons that you've heard people talk about throughout this conversation this morning. It's very task-oriented, it's very check-the-box oriented, and not really consistent and coherent in terms of how it works. It also doesn't speak to the interplay among systems. And so you've got a healthcare, I would say medical care system, because I think we are part of the healthcare system as well, who doesn't really understand long-term services and supports. We have a mental health system. We have all these other systems. We have a criminal justice system. We have all these systems that need to work together. And the methodology we have right now is not consistent with the interplay there. I do think that there are probably other states who've done this already and are way ahead of us. And it would be interesting to see what they've set as what they consider those values that they want to purchase in a LTSS system. What is the purpose of home care? So I think those are important questions to ask. We do some work with the Veterans Administration. We do some work with some private insurers, and they're pretty clear what their outcomes what they want their outcomes to be. We use pre and post test methodologies with some of those other payers who while I'm not sure it's all the way to where it needs to be, I do think that there is more movement there in terms of really trying to get to outcomes than there are in the system that we're working in with MaineCare. So I look forward to those conversations. I have some thoughts about what I think are some measurements that we can use universally across the systems. I thank you for the opportunity to have input here today.
Okay, thank you. I'm not seeing any more hands or anything in the chat, Julia.
Okay, great. Thank you so much. Can you go ahead and advance to the next slide? I think it's our wrap up slide. Yep. So we just wanted to remind everyone that the written comments can be sent to ratesettingeval@maine.gov. And thank you very much. I'm just going to check the Q&A to make sure. We will be posting these online. There will be a link available in order to be able to access them. If you think of something later that you forgot to tell us, please don't hesitate to let us know through the email. Excuse me. We're happy to take any comments through there. If there are, we just want to give everyone a last opportunity. If there's something that you wanted to tell us and you didn't have the opportunity, just take a couple of minutes here for anyone who would like to give sort of like a closing comment or question. We really appreciate you guys taking the time out of your busy days to spend some time here with us, and appreciate all the care you're providing to seniors and people with disabilities in Maine. Don't think I'm seeing anyone. Are you seeing anyone, Jillian? Any new hands or?
I am not.
Well, great. Thank you so much, everyone. We appreciate it. And like we said, we'll post the recording if you want to live through this experience again, or if someone was unable to not listen. And we look forward to speaking to you again, hopefully in phase 2. Thank you.